Conference will now be recorded.
In shambles.
This conference will now be recorded.
Yeah, we've been trying to figure out blood. Sorry. Okay. So, whoever is on my trauma symposium list, I have your tickets. So, if y'all want to just grab them, like when we go on break or after class, whatever. It should be going right. Good job. Good job. I'm also going to pass these out. So they're normal ranges for vital signs for all ages. Yay. So you guys can refer back to these. So I will say, like especially with like kid vital signs and stuff, that the numbers might change a little bit. Like you'll read one textbook that says one thing, and then another textbook that's like a few numbers off, but it's like in the same realm. So just know whenever we're like getting ready to take our NREMT, we're getting ready to take our NREMT. Whenever they ask you questions in regards to like normal for vital signs or normal for like doses, they're never gonna give you like 1 point difference. Like, okay, tachycardia is at 100 beats per minute, 101 or 102. Like it's never gonna do that. It's gonna be like vastly different numbers. So this gives you a good like general idea of all that stuff. Same thing goes with like whenever you're talking about like if you ever get a question about like a dose for a medication, same kind of thing. Like you'll have some that are just completely wrong, and then you might have some too, the numbers that look the same, but always look at like the milligram or like microgram, because that's where they'll throw you off, because it'll be the same number, but one will say milligram, one will say microgram. So this is just a reference point. All right, so today we're going to learn how to obtain vital signs and when it is necessary. There's some, I don't think these hook up to that though. I just grabbed some things to show. Okay, we're gonna identify the parameters for normal vital signs, so you guys have your sheets. And then we're gonna learn when to reassess vital signs for different patients. There is a textbook answer whenever you're gonna reassess your patients. 35 minutes. It depends. So if they're, according to the book, if they're unstable, it's every 5. If they're stable, it's every 15. Yeah. What if they're stable, but possibility to go unstable? Every 5 minutes. 5 minutes. Sometimes I do 10. Sometimes I do 3. Sometimes I do every minute. We have something called a turbo cuff that'll take as many blood pressures as it can in 3 minutes. So it's going to change. But the textbook answer, you're right, is every 5 minutes for your unstable. All right, so what are vital signs? They're outward signs of what's going on inside of the body. So what are some vital signs that we obtain? Blood pressure, pulse ox, respiration rate, temperature. Yeah. So there's one thing not on this list that I am going to disagree with, but your book says it. So. Your SpO2. Your SpO2 is not considered a vital sign. I disagree. I feel like it's one of the most important vital signs that we get, but apparently it's not a vital sign. So, yeah, here's all of our vitals that we take. So one that you wouldn't really think is like a vital sign is skin color. Obviously the temperature, like we take a temperature, that's like obvious, but skin color, temperature, and condition. So if it's pale, cool, and clammy, if it's warm, hot, and dry, pale, hot, and dry, like these are things that we want to take note of whenever we're assessing our patients. And these can change. Like we've had patients, we pick them up and they're all clammy at first, and after we do some treatments, then they're no longer clammy. Like we want to document that and take note whenever we're reassessing our patients. All right, so this is just some general baseline tidbits. So every patient that you transport should have at least 3 vital signs. We want to get a baseline. So we want to see what they started out as. We want to see what they're maintaining and what they are. So this gives us like those trends is what they're called. So 3 vital signs per patient transport. Now, if we're getting a refusal, a lot of times we'll get like 1 set of vitals or 2, depending on what's going on. Sometimes more than that. If I get called out to like somebody that has a cough and we show up and they're like, well, we just wanted to get checked out, we'll probably just get 1 set of vital signs. Now, if I go out on somebody that's diabetic and really hypoglycemic, and I have to give them sugar and then they want to refuse once they wake up, I'm going to get more than 1 set of vital signs. So it's all kind of like situation dependent. But whenever we transport at least 3, I will say that I think it's best whenever you go, yes. Whenever we go on patients to get that first blood pressure is a manual blood pressure. Especially if that monitor, we don't always trust our monitor, right? So if that first blood pressure pops up and it's like 70 over nothing, I'm probably gonna take a manual blood pressure. And think if it's like super high, or if I see like signs of my patient and I'm like, this doesn't make sense that their blood pressure is normal, but they look like this. Like I'm gonna take a manual blood pressure. But our machines do take automatic blood pressures. You can set them up to however long you want to take them. So every 5 minutes, every 10 minutes, however long. You can change all that in our monitors. All right, so pulse. Everybody can find their own pulse, I hope. What's this pulse called? Radial pulse. Throw that in
Work that thing.
there. All right, so our fingertips, not our thumb. We learned that in our CPR class. Because anytime an artery crosses over a bone is where you can feel pulses, except for right here. That's not really a bone you're pushing against other structures. But anywhere that your artery sits next to a bone is our pulse. So it's palpable. So every time we palpate a pulse, that's you feeling a pulse. It's just another fancy word for that. So every time that blood gets pushed through those arteries by our heart, it creates that wave, right? And that's what you feel is that wave of the blood flowing through the artery. All right, so whenever we're taking a pulse, we consider the rate and quality. So how fast is the pulse? Is it too fast? Is it too slow? Is it feel okay? And like whenever I'm first assessing a pulse in that first ABC assessment, that primary assessment, I don't sit there and count it out. Like if I'm going to do my primary assessment and I'm checking circulation, airway, breathing, I'm just going to come up, I'm going to feel it. I'm going to feel if it feels fast or slow, or if I feel it at all. And I'll just take like a mental note, like, okay, that feels kind of fast, or that feels way too slow. And then another thing you want to look for is the quality. So is it like strong? Is it bounding? Or is it like a thready pulse? And you'll feel like a major difference. Hopefully everybody here has like a normal pulse. But if it's bounding, it'll be like super strong. Somebody with like really high blood pressure usually has a bounding pulse, whereas somebody with a really low blood pressure will have like a thready pulse. Does that make sense? So whenever we're counting, I will say the trick to this, whenever you're learning how to take vitals at first, is you do the pulse and the respirations kind of at the same time. So all it does is it takes a minute to do both of them. So I count the pulse for 30 seconds and then I times it by 2. The only caveat to that is if that pulse is irregular, like if someone has AFib or a weird heart rhythm or something and it doesn't feel regular, you're supposed to count it for the full minute. So put your fingers on, count for the full minute or 30 seconds or whatever. Some people count for 15 seconds and times it by 4. I'm not that good at that. So I'm a 30 times 2 kind of. So the normal rate for a pulse, 60 to 100. Now, if it is 100, is that considered tachycardia? Heard the book. We had to look this up last year because we were like, 101 is tachycardic, 100 is normal.
So I'm not going to say never, you shouldn't see a test question that puts you in a position to answer something like that. It's not going to be like, is 100 considered tachycardic or normal? It's going to be something outlandish. It's going to be like 130 or 120 or 110, right? So they're not going to put you like right there and be like, is 99 considered or is 60 considered bradycardic, right? Like it's going to be like, 30 or 40. So don't stress too much about that. But for your textbook, 60 to 100, anything over 100 is considered tachycardic.
So if it's greater than 100, called what? Tachycardia. If it's lower than 60, what's it called? Good job. So the trick here is I count the pulse and the respirations, but you never let the patient know that you're counting their respirations. Because as soon as you're like, I'm going to count your breaths now, they're going to start breathing funny. So 30 seconds for the pulse, 30 seconds for the respirations, unless they're irregular, and that goes for both of them. We'll talk about that for respirations. But if it's irregular, you count it for the full minute. No yawning. It's too early.
Ready for a nap?
All right, so quality is the rhythm and the force. So when we're talking about pulse quality, so we're talking about rate, rhythm, and quality, right? So rhythm is it regular or irregular? And then if it feels bounding, if it feels normal, is it strong or is it thready? Whenever somebody has an irregular heartbeat, a lot of times you can just feel it. Like you should have a little metronome going in your head, and if it doesn't line up with your metronome, that's an irregular heartbeat. Some people it's super obvious. Some people just throw random weird beats, so you could be sitting there and it feels normal, and then you feel it again like 30 minutes later, and you might get one irregular beat. For the most part, it's regular. But anytime you go to feel for a pulse and it feels irregular in any way, whether it's too slow or irregular, make sure you're letting somebody know. I made that mistake when I was new. I was like, yeah, I'm counting the pulse. It's whatever. And then the AEMT I was working with checks the pulse. I was brand new. I was still doing my third rides. And she's like, you should have she chewed my butt. Was like, you need to tell us when it's irregular. So tell somebody if it's irregular. I learned that one the hard way. So, all right. What's that pulse called? Radio. Good. What's that pulse called? Behind the knee, yeah. That's the behind the knee to this. Does anyone want to just take a shot at it? Huh? It's your popliteal. So to really find it, you need to use both hands, and you kind of grab their knee and push in, but you don't want to push in too hard. And it's right here behind the kneecap. This is probably the most difficult pulse to find. I have yet to find one on a patient. If I need to find a distal pulse that's in a leg, I always just go to the foot, because I can never find this one behind me. What's that one called? Brachial. Good. How about that one? Pedal pulse, or the dorsalis pedis. What about that one? Femoral. Good.
If you do find this pedal pulse, try to mark it, because that's also not like the easiest pulse in the world to find. And so if you find it on somebody, if you've got like a marker or pen or whatever, try to like put like an X right there. That way, if somebody comes behind you to reassess it later on, it's easier to find, because that thing's kind of a pain in the dick to find sometimes.
It's true. I would recommend practicing finding a pedal pulse on like yourself or like anybody that you're around, your friend, your husband, wife, kids, boyfriend, whatever. Because they're so hard to find. The more that you find them, the easier it'll be to find on a patient. So just randomly, we'll be sitting there watching TV and we're like feeling each other's pedal pulse. Which one of these is considered a central pulse? Femoral and carotid. Good. So if someone's unconscious or unresponsive, those are the first two that we're going to go for. Usually the carotid, but the femoral would count. If the patient is less than a year old or less, you need to check the brachial pulse because their heads are so big, their little carotids are hard to find. So that's our next best. And we already talked about. Yeah. I think it's just because that's like a lot easier if you're gonna walk into someone's house and like try and fill the kid's femoral. Some patients might go in
Yeah.
and question you.
What the frick are you doing?
Yeah, like I feel like this
Why are
is
you
more
screaming at
socially
me?
acceptable than like. Yeah,
Even people
that's
look at
what
us
it is.
weird whenever we're doing this to like grandma. If we're like, oh, I've got a pulse at the carotid, like somebody will go down to the femoral and be like, yeah, I got a pulse too. Well, if you're sitting there watching us like work on your grandma and you see me stick my hands down grandma's pants, you get a funny look sometimes.
Yeah, I remember like,
We know
what
why
the
she
hell?
got a pulse back.
Yeah.
Crazy.
Pulse might be a little rapid.
It's so funny because
That's
little
what Jazz
babies
called him,
love
honey.
grandma.
He's got that southern accent when
He does. He does.
She's
Like,
like,
hey,
do that
darling.
again.
All the old women love him.
I'm used to it at this point. Between the old ladies in this county and freaking Kim at dispatch, bro.
I bet she loved you.
Yeah. She does.
Yeah, it's funny.
She'll let you know too.
All right, so in regards to vital signs, so there is something called cellular respiration and pulmonary respiration, right? But when we're talking about it in obtaining vital signs, it's just how many breaths they're taking. So again, rate, rhythm, quality. So how fast are they breathing? Is it fast or slow? Is it regular or irregular? Are they taking decent breaths? Are they taking really shallow breaths? Are they taking really deep breaths? So these are all things that you should kind of take note of as you're watching your respirations. Again, don't tell the patient that you're taking their breaths. You know, unless it's an unconscious person, then you can do what you want. But if I'm like, hey, I'm gonna count your respirations now. My name's Doug. I am here to get my assist elderly. And then they're gonna sit there and be like, they're gonna breathe funny. So don't let them know that you're gonna take a respirations. I also have this app on my phone. If you guys have an Apple Watch, I think Samsung watches can do it too. It's called Med Timer, MD Timer. I'll show you later. I can pull it up right now. It's like a little green looking thing. Actually, I think it's like heart and lungs. Maybe it's just on my watch. I don't know why it's not on. It's called Med Timer. I'll find it. So it's really cool because it has a little timer on that pops up on your watch face, and you can choose like 10 seconds, 15 seconds, 30 seconds. So you hit it, and then you just have to tap your watch. You don't even have to like be touching the patient. You just stand there and you like tap, 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 and then it'll count the respirations for you. Super awesome. I love it. I use it all the time, especially in kids because they breathe so fast. It's kind of hard. You just tap every time they breathe, and it'll calculate it for you. Super fun. All right, so the number of breaths that the patient takes in 1 minute is your respiration rate. So again, I take it over 30 seconds. I times it by 2 unless it's irregular, and you're supposed to count. Their normal is 12 to 20 breaths per minute. If they're normally breathing 12 to 20, the word for that is euapnic. That's not a very commonly used word. But if you ever get a test question that's like, you have a euapnic patient, they're breathing normal. That's what that means. Or your patient presents with euapnea. That's regular breathing. Now, if it's fast, what's it called? Tachypnea. And if it's slow, bradypnea. Or bradypnic. Either way. So if it's unusually too fast or unusually too slow, we know this from our last 2 chapters that we might need to either administer oxygen or help assist with ventilations. If their respirations will not sustain life, we need to breathe for them, right? So if they're taking 32 breaths a minute, but they're super, super shallow and their oxygen sucks, we need to breathe for them. Now, if I have a patient that got kicked in the chest by a horse and they're breathing 32 times a minute, they're breathing shallow, I'm not going to sit there and bag them. Depending on their oxygen saturation, I might put them on a little bit of oxygen. But those are some things that we want to consider before we just go in and bag patients. There's no one answer of like, if they're breathing 32 times a minute and shallow, breathe for them. There's no like one solid answer. So that's a lot of just like obtaining what's going on with your patient, right? That was like a big confusion last year whenever we started running these scenarios. We had a patient that was breathing fast and shallow, and they're like, we want to bag them, or I don't want to bag them, and there was some like communication, like differences. So, are they oxygenating? That's what you want to ask yourself. Are they getting oxygen where they need to go? All right. So, normal. We know what normal looks like. We're all breathing normally in here right now. Shallow. That can be kind of hard to pinpoint if you, depending on like how much you got going on. But for me, like the first few months of doing this job and like running a bunch of patients, I had to like step back and be like, okay, are they breathing shallow or normal? Like I had to ask myself that question. Now it comes like second nature because I've seen it so much. But at first, sometimes you have to kind of step back and be like, does that look shallow or does that look normal? Because it can be hard to kind of differentiate the two. All right, labored, are they having a hard time breathing? Do you see intercostal muscle retractions? Are they in that tripod position? That would be like your labored breathing. And then any kind of noisy. So if they're wheezing and you can hear it from the door or just hear it, if they have stridor, if they're gurgling, any kind of abnormal noise, that would be a noisy. What's it called? Does anybody remember the word for lung sounds that are abnormal? Starts with an A. Adventitious. Adventitious lung sounds are any kind of abnormal lung sounds. ADVENTITOUS. Adventitious. Adventitious. I think that's how you spell it. I have no idea.
Oh, bro, I didn't graduate high school. I don't know.
I was trying to break down the words you can remember. It has vent in it.
Oh, yeah.
Breathing and then add.
Add the sounds. That's good. I like that. All right, so any kind of unconscious patient, always observe for irregular respirations, whether that's like those agonal respirations that are really slow and they look like that guppy fish that's been put on like a guppy breathing, or if you have something like this. So if you watch his respirations, you can see that they're very abnormal. There's a shallow breath, a little bit deeper of a breath, deep breath. So this pattern is called Cheyne-Stokes. Don't worry about the spelling, we'll talk about that later. Just want to get it in your brains now. So whenever you have somebody with a really bad brain injury, they present with this kind of breathing. This is called Cheyne-Stokes. It's like a shallow, shallow, deeper, deeper, and then they don't breathe. And then shallow, shallow, deeper, deeper. It's called Cheyne-Stokes. You ever see an unconscious patient with possible head injury? This is a bad sign. It kind of goes with that decorticate, decerebrate thing that we were talking about earlier. You'll usually see those two things hand in hand, and they're looking up Jesus' skirt. Hey, how's it going up there? Can I have dinner? It's not good. All right, skin. I had to put a background on the skin. So color, temperature, and condition. It can also give you a lot of good information. So if somebody is hypoperfused or in a shock state, their skin usually tells you what's going on. So You can look at their nail beds, you can look at the inside of their cheeks, you can even pull down and look under like their eyes right here. So if someone's like really, really dehydrated or really, really dry, you'll see it like in their eyes, and in their mouths. And then any kind of like blue, pale, you'll see it on the hands and feet. And then back of your hand, again, whenever I check, I'm checking for that pulse and I kind of take note like, yeah, they feel like they're really warm. They feel like they're normal temperature to me, or they feel cold and clammy. If I feel for a radial pulse and I feel that they feel kind of cold, I kind of will like go up to their core and feel what their core feels like. 'Cause sometimes, like right now, my hands are freezing, but my core is warm. So that's kind of what we're looking for. My hands are always freezing, but I don't count.
So how come, like when somebody gets flu at stomach all of a sudden and they kind of have that little confusion?
Yeah.
Why? What causes that?
So it depends. Like obviously, if they're having like bleeding internally, actually out of the tummy, but like somebody that's in a lot of pain suddenly, they can have something called like a vasovagal response. And so they mess with their little vagal nerve in the back of their throat, and their heart rate will drop, and their blood pressure will drop, and it's all from just pain response. So it kind of depends on the person. Some people have it, some people don't. But that's usually like if we have somebody that's like broken an ankle or smashed their hand, that's the particular one. I've had a lot of patients smash their hand and they'll go like pale and pass out. And it's all for the same reason. It's some kind of pain response. Unless it's something else going on, like if they're bleeding internally or like, you know, their gut's dying for whatever reason. So that would be another reason to go that way. The most benign of all of those things is a pain response. All right, what's that called? Good, cyanosis. It's blue-gray, it's called cyanotic. What does that mean? Hypoxic, good. This is the best picture I can find.
I got this wrong, just so
You
it's
did,
clear.
I was
She was like, what is this? And I was like, lady.
White lady. So pale, pallor. So she looks pale. You can kind of see her eyes or something in a little bit. Possibly, yeah. This was the best picture I could find. I pulled it off Google. What about this? Flush, yeah. It's like that redness flush. Some people just look like this all the time, like rosacea. But if I go out to like an allergic reaction and they look like this, that's a different story in my head.
If you ever met Adrienne Burkhardt, she looks like this all the time.
She does.
She like
She's just red all the time.
what is jaundice?
And if she gets embarrassing, it's worse.
Yeah.
Jaundice.
They start sweating.
What does jaundice kind of tell you? Yeah, their check liver lights on. Yeah. So for kids, you want to check a capillary refill. So you can check it on the bottom of their foot or on their fingers. Some textbooks that you read will say to check this on an adult. I will say that like it's not that accurate on an adult. Like even me right now, my cap refill is super slow just because my hands are cold. It's gonna be more accurate in kids. So all you do is push down and you wait for that white to go away. If it takes longer than 2 seconds, that tells you that there's something going on. So here's an example of more than 2 seconds. On Mississippi, to Mississippi. So if you're seeing that in a kiddo, that's a bad thing. So you're waiting for that white to go away. All right. So pupils. We carry around these little lights. They're pupil pen light. Don't go shining LEDs into your patient's eyeballs, please. You can use the
Hey, Jenny said do it.
He's burning a hole in your vision.
If you do, if the only light you have is like some sort of like small like LED pin light, when you do this, you need to start like way outside of their peripheral and like move in until you get a pupil response and stop. They'll freaking open it up directly in their freaking eyeball and be like, flashbang, gotcha, open.
Yeah. You can also use like the lights in the room or in the ambulance. So just cover their eye and then uncover it, and it will do the same thing. These are nice because they give you the little sizing thing on the side of them. So whenever we talk about like people's sizes, this gives you like, oh, that's 3 millimeters. Like I can see it, and it gives you a little thing. So if it's dim, their pupil should dilate, and then if you shine a light in it, it's going to constrict and get smaller. What medication or drug will cause pupils to be pinpointed? Opioids. Any kind of narcotics, opiates, opioids, all that stuff. So whenever we're referring to this, if pupils are like they should be, we'll write that the pupils are perla. So what that stands, we won't write pupils are perla, we'll just put perla. Because it stands for pupils equally round and reactive to light and accommodating. Sometimes they'll throw the A like here, so it'll be like PEARRL. So if you ever see this written down, it just means that their pupils were normal. So what they mean by accommodating is if I shine a light in my right eye, my left eye is still going to constrict. They work together. So sometimes if you shine a light in the right eye and they have some kind of brain injury or something going on, even injuries to the eye, that other eye won't respond. And you want to take note of that. Especially in like head trauma patients. Sometimes it's normal. First thing to ask, if their other eye doesn't move, and they're talking to you, you have a fake eyeball. Because I've made that mistake.
Some of those like fake prosthetics are super real looking. Who's chatting? Somebody wrote something in the chat. Maybe she didn't.
I think that same noise happens whenever somebody like leaves.
Oh, okay. Who left?
CJ.
Come back.
All right, so this is what it looks like whenever you shine a light in for old people. So medical terminology, this first one is normal. What about this one? Dilated. Called mydriasis. Am I ever going to remember that? Probably not. This one, if they're unequal, this is called aniscoria. Anisocoria. Aniscoria. This word. So if they have pupils that are unequal, that could be a sign of like a head injury. It can be a sign of certain medication administration. So some kind of nebulizers, especially the ones that we use on the ambulance. Bless you.
Oh, shit.
Are you good? You got a head injury? So that medicine that we put in the nebulizer can get into their eye and cause anisocoria. So this is called meiosis if they have pinpoint pupil. Meiosis, when I was taking my national registry test, they threw meiosis at me. I had no idea what it was. They're like, your sneezes are contagious. Bless you. It's one of you guys next. It's moving up the roads. So the meiosis, they threw that at me. They were like, hey, you have a patient that's unresponsive with meiosis. Now I'm like, oh, that's an overdose, but little EMT, brand new EMT Becca, I don't know what meiosis is. He's dying. But that's all this. Pinpoint pupils. But the NREMT likes to do that. They throw medical terminology at you, and you're like, well, crap. All right, so unequal pupils can be caused by a lot of different things. So malignant factors, head injury, eye injury, we were talking about that. Even like someone getting hit like in the face and it causing like a rupture of anything in the eye, it can cause like your one eye to not be responsive anymore. Getting hit in the head, so concussions can cause it. Usually if their pupil's blown, they're not gonna be talking to you. But sometimes you can have where it just affects the one eye and they're fine. They're just a little concussed. Again, eye drops can cause it. Some of our nebulized medication. Benadryl, if it gets in your eye, it would cause the same thing. So, certain kind of chemicals. So, that's one of those things you're just figuring out leading up to. Like my eyes, they're unequal, slightly. But if I had fell and hit my head and you guys were looking at my eyes, you'd be like, oh crap, but mine are like normally abnormal. I probably have a tumor, actually.
This
Yeah.
word right here.
Yeah.
You said that.
All right, who wants to say that word?
I'm not even gonna try, because I tried yesterday
I
and
thought
failed.
I was having a FIGO
Back to
It's just a fancy word.
I had to look up that stupid word and see what it meant. It's all blood pressure cup. What the?
Why don't they just call it a blood pressure cuff? It's a sphygomanometer. Jeez. All right, so blood pressure cuff. We have different sizes. So we got adult, we have small adult, we have kids, we have infants. I'll just pass these around. We have large adults, we have thigh ones that we use.
If we got the thigh cuff out, I'm not having a good day.
Yeah.
Or is it for a child that is just that great?
Or they have really big ones. Or use a
So the biggest thing about applying these, and I got some more.
Why is the thigh?
Because that means we dealing with a hefty person. And my
Either
back hurts.
hefty or like really sick. Sometimes we have patients that we can't do blood pressures on their arms, so we'll put it on their thigh.
What around their neck?
The calf,
Like-
not
Some
the
patients, I want to put it around their neck. Not aggressive.
the calf, you can do like a blood pressure around the calf, upper arm. So to obtain a blood pressure, you need three things. You need a patient. You need a sphygomanometer, and then you need a stethoscope. So those are the things. So your blood pressure is the force of blood going against the walls of your vessels. So your systolic is whenever that left ventricle squeezes and it's pushing out blood to the rest of your body. And your diastolic is whenever your heart relaxes and refills with blood. So these are what we're trying to obtain, is your systolic and diastolic numbers. There's something else here. So squeeze, relax, squeeze, relax. Normal is 120/80. So as it's squeezing, that's when you get your systolic and diastolic. So whenever you're taking a blood pressure, you're listening for right? So you're listening for that heart rate in the artery. It's accommodating. So it's whenever you shine it in like your right eye, your left eye should do like an constriction. They should work together. And if they ever don't work together, it needs to be done.
No.
Uh-huh.
Gotta go to the fire department a little bit.
Hmm?
I gotta go to the fire department a little bit.
So you want to use my-
And that new fire department, the building's coming right along.
I'm excited.
They gonna have a gym in there too?
Gym,
kitchen.
He just wants the gym.
Maybe.
I do.
Oh, I'm just like. No, that's
Tiny.
All right.
Mhm.
He wants double gym on that.
So this is kind of how I think about it whenever I place a blood pressure cuff. Who in here is taking a plan of blood pressure?
I don't need to look.
Okay, so whenever we start like going over this new skills, we're gonna teach y'all again. But if you want to help other people that haven't taken them, you're gonna be taking blood pressures on yourselves or on each other. So I draw like a cross in my mind right here, right on Cookie's face. Baby. So I draw a cross in my mind, and then I go in this top like inner corner, and I feel for their pulse. right? So I can feel his pulse. You can probably find your pulse if you feel in the same spot.
Because isn't it straight line from someone over here?
So you have two. You have two that run down. So you have a radial artery and you have an ulnar artery. So you're going to be feeling the inner one, like the bottom of your brachial pulse in here. And it's going to be above your elbow, so it's still considered your brachial. Thank you. She's like, right here. So as I find the pulse, it's usually on this upper inside here. That's where you're going to want to feel it. So there's a marker on here. So it says artery, left arm, right arm. You want to line that up with the artery that you're feeling. So whenever you're putting this on somebody, you're going to make sure that it fits them. You want this white line where it says index, you want it to fit in the correct range. There's a range here. If it doesn't fit in that range, you need to get a blood pressure cuff that does fit. It will be inaccurate if you're using an improperly sized cuff. So I'm going to find his artery. I'm going to put it here. I'm going to wrap it around. Now I can see the range. He's in the range. He's good. Every patient, it hurts and like stuff. All right. Motherfucker.
She hated that
squeezing me too
thing.
tight. They're like legs shot off. They're like, my arm is for the blood pressure cuff. Okay. So this can disconnect. I like to take it off and clip it to their shirt or the bed or whatever I'm doing. Because it being right here, sometimes it can slide around. So just so you know, it does. So once you have it clipped, you hold this cuff in your dominant hand. Mine's my right hand.
Almost.
So I'm going to make sure this is locked all the way down. So as I pump this up, you'll see this start to go up a little sphygomanometer part. So it'll go up. So as I'm doing this, I'm going to have my stethoscope over that artery that I felt. And so I'm going to listen. I usually pump it up to about 160. And if I still hear the pulse, then I'll just pump it up another 20. So I'll pump it up until I don't hear that anymore. And then you slowly release it here. So as you slowly release this, it'll go down and you're listening for a thump, thump, thump in your stethoscope. So whenever you hear that first thump, 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 that's your systolic blood pressure. Now, whenever you lose it, you're paying attention to these numbers as your little meter goes down. As soon as you stop hearing it, that's your diastolic number. So we'll practice, because I know it's like hard to just watch me do it. Another thing that you can do, if someone's really, really sick, or if I don't have a stethoscope and I'm just trying to get a quick blood pressure, is I'll find their radial pulse. This is called taking a blood pressure over palp. So I'm not even using the stethoscope. So I find his radial pulse and I pump it up until I lose his radial pulse. Once I can't feel it anymore, I get a systolic number and that's all I get. But a lot of the medications that we give, that's all we need to know is the systolic. So that's another way you might see other people doing it. It's great, especially in the back of an ambulance when you can't hear anything, if you're moving around. And then you'll just write it like 100 over P or palp. So that's what, whenever we calculate.
Will the gauge start moving before you hear it?
Huh?
Will the gauge start moving before you hear it?
Are you talking about the little needle?
Yeah.
So sometimes you'll see that needle come down, you're releasing the needle. So you're in control of it going down. But a lot of times I wouldn't like put all of my paycheck on it. But a lot of times right where you hear that systolic at first, you'll see the needle kind of start bouncing. Does that make sense?
Yeah.
Does that answer your question?
Yeah.
Okay. Okay. So we just talked about this. Find a distal pulse, distal to whatever you're doing. So if you're doing it on the calf, you find a pedal pulse. You can do it on the forearm and find a radial pulse. So that's super nice, especially if someone's really, really sick and I don't have an automatic blood pressure cuff. I can just take a lot of blood pressures. All right, this is something I don't think is talked much about in your book. It's called a MAP, or mean arterial pressure. This number whenever we take a blood pressure, it pops up on our monitors. I will say that any kind of automatic blood pressure cuff, their most accurate number that they give you is the MAP on the blood pressure thing. So the automatic blood pressures measure the MAP and they guess the systolic and diastolic. So if you ever watch a patient and your blood pressure cuff has like popped like multiple numbers, but you look at the maps are always pretty close together. So what this is, there's a whole equation that goes into it. It's on the bottom of that paper that I gave you guys. You don't need to memorize that equation by any means. At some point you will if you want to continue to progress in EMS. But that's how you obtain a mean arterial pressure. So it's the systolic plus diastolic times 3 divided by whatever. Plus 2 divided by 3. So what we're looking for is a normal MAP is 70 to 100. Yes.
This one's times 2. It is times 2.
I think your paper is correct. Let me double check it. Look at me. Good note. Good job. Good job. Hold on. I told you that I wasn't good at math.
That's the same thing.
It's-
That's the
yeah.
same thing, because it'd be 2 times your diastolic.
Oh, you're
Whatever's in
right.
parentheses.
You right. Yeah.
Yeah.
Because the
What about the
2.
minus?
There's no minus.
There's no minus.
It's
it's
the
just the
systolic
underlying.
plus 2 times the diastolic divided by 3.
is equal to systolic blood pressure.
It is in parentheses.
Plus.
times
You know how
2.
you multiply the parentheses by whatever's on the outside?
Do you remember PEMDAS?
I'm also not a math person, so I'm over here Googling it.
It did look weird at first. I'm like, oh wait, it's the same thing.
I'm glad you were here. That's why it threw me off for a second. I was like, what? I said, oh, that's just math.
What is that? PEMDAS?
Yeah, PEMDAS.
All right. So normal is 70 to 100, right? So like I said, I'm not going to be having you guys memorize how to obtain a MAP, but just know whenever your automatic blood pressure cuff pops up with a blood pressure, there's a little number in parentheses right next to it, and it is your MAP. You want it to be greater than 65. 70 to 100 is normal, but greater than 65 is telling you that all of their vital organs are being perfused. So we are going more off MAP than we are systolic and diastolic 96% of the time in real life. You guys are going to learn normal for blood pressure, but just know that this is very, very important. Somebody's blood pressure might seem really, really low, like 90 or 40, but they still have a MAP of 65. So, like, that's okay. I'm not going to sit there and start dumping a bunch of pressors in them or giving them a bunch of fluids or freaking out because their organs are still being perfused. It is millimeters of mercury. So your blood pressure is measured in millimeters of mercury. What else? There's other things. It'll come to me later.
So weird.
There's certain things like the measurement of the, you know how like that end-tidal cuff or the ET cuff like blows up. That's measured in centimeters of water. I'm like, how? What? That makes no sense in my brain. But it's weird. So millimeters of mercury is your blood pressure. That's what that's measured. All right, temperature. We have a narrow range of temperature that allows us to function as humans. Some people kind of sit a little bit lower or higher than others, but there is a range. If you're grossly out of that range, like if your temperature is 104, those brain cells start dying. Now, if your temperature is less than like 90 degrees Fahrenheit, you're probably going to die shortly after if you don't start getting warmed up. So it depends on the time of day, your activity level, age, and where it's measured. Where is the most accurate temperature measurement? Of the butt. A rectal temp is the most accurate.
We're not doing rectal temps in
I don't do rectal.
You gotta wrap that up.
Yeah.
That's why nurses get paid more than me.
They are the most accurate though. So anything towards the core is gonna be more accurate. Up the butt's the most accurate. In the mouth, I was taught, and I don't see it in your guys' textbook anywhere, but just in case you hear it again, it's not completely abnormal. But if you're doing anything like away from the core, it's like behind the ear, in the ear, above on the forehead, you're supposed to add 1 degree to it. So I was taught that. Were you ever taught that? But I didn't see it in your guys' textbook. So if you find it, let me know, but I didn't see it. But if you do like a core temp, like or in the armpit, you should be good. Also, your thermometer, the quality of the thermometer is also dependent. So older folks, they have a more difficult time maintaining body temperature. So a lot of times as you get older, your temperature kind of changes a little bit. Usually it goes down, like core temperature goes down. That's why old folks like to keep their houses at like 96 degrees all the time, because they have a hard time maintaining their own body temperature. Also, like babies, anybody who's ever dealt with like little babies, they're sitting there screaming and crying, and they're like bright red. They'll feel hot, they'll have a temperature, but as soon as they stop crying, they'll kind of cool down a little bit. So it kind of depends, like what's going on with your patient. All right, here is your normals. So hypothermia, low temperature. This is in Celsius. So your normal for Celsius is 37, or around 37. Now if you're up like 40, if you're higher than 40 degrees Celsius or 104, that's hyperpyrexia. And then fever or hyperthermia, this is still hyperthermic, but they just give it a whole nother name, like extra fevery. But hyperthermia is greater than 38.3 degrees Celsius or 99.5. So I will say it's important just to know that normal for Celsius is 37. So if it's above that or below that, I still Google what it is. If it's like not 37, I'm gonna Google what it is in Fahrenheit, or I'll put it in our charting system because it converts for me. But just know 37 is normal. I think that our mannequin in here, it only gives Celsius. It's 101 and 103. Those don't worry about. Don't even worry about them. We are missing a couple degrees here. Still febrile. Oh yeah, so if someone's running a fever, it's called febrile. So if I say someone's afebrile, that means that they don't have a fever. Fever. That B lives there now. Fever.
Fever. Mm-hmm. I know some of these words.
I know some of these words. Everybody got it? Almost. Okay. Now, like kiddos, if they're living at like 101, like if they're sick and they have a fever of 101, so a lot of times you'll have parents or like providers that won't treat it because that's their body like killing off what it needs to kill off. So it just depends. Like for me personally, if I'm going to treat a fever, if I have the means to, like we carry Tylenol, is how uncomfortable the patient looks. Because having a fever sucks. Like you are just uncomfortable having a fever. Like how uncomfortable does this kiddo look? Is the kiddo having febrile seizures? Like just kind of read the patient, but just know it's like not completely abnormal to not treat a fever of like 100. All right, SpO2, that's not a vital sign. That's a silly.
Mm-hmm.
It's a vital sign. So, oxygen, amount of oxygen present in our blood. So the pulse ox, what it does is it shines a little infrared light in between our tissues, or where we put it, and it's measuring the amount of oxygen that's on our red blood cells, or the amount of whatever is on our red blood cells that is attached to our hemoglobin. I say that because if we have like CO poisoning, like carbon monoxide poisoning, it'll read those carbon monoxide molecules as oxygen. What it does is it's just like reading each little individual and like, oh yeah, they got oxygen. They give you an average. And that's where we get that. What's our normal pulse ox?
95 to 99.
Good, 95 to 99. Everybody got that written? So we have different kind of pulse ox probes. You got this one. Now, if I have like really thick fingernail polish, like dark fingernail polish, it'll have a hard time reading through it. What you can do is just turn it to its side, like that. That works really well. We have little clippy ones that will go on ears. You can put it like right on the earlobe. I like to put it on the inside of the ear right here because it holds a little better. It's like to get inked off this will kind of hold it. We have the sticker one. You'll see it on the forehead, around the fingers. Do we have any there?
This is our spare one.
Oh, okay. I'll let it slide this. So Mikey talked to you guys about like some of this big sick, little sick, medium sick, like what kind of oxygen you're gonna administer to them, right? So big sick, severe. That is like our non-rebreather status.
Attach pads.
Valencia, come on. Mild hypoxia, 91 to 95. Significant or moderate is 86 to 90. Again, if your patient's talking to you, they don't have any kind of shortness of breath, they call for something else, and they have a history of COPD, and they live at 90% or 89%, and they're like, yeah, this is my normal. Don't go shoving, like don't overdo it, right? But you want to treat the hypoxia. So things that can affect our SpO2 reading, shock or hypothermia, any kind of diminished circulation to that extremity that you have the SpO2 monitor on is gonna affect your reading. So that's where that pleth wave comes in that we talked about last week. Does everybody remember the pleth wave? You want it to be like normal. So other things that can change. You gotta pull up there. See, that's a good pleth wave. Right? Now wiggle your finger around. Okay, excessive movement. It can affect your oxygen. Especially like his is still saying 97%, but sometimes if they're moving a lot, you'll see it actually drop. So that's why we always look at that pleth wave whenever that number turns real funky. And then anemia. So if they have
So all I did was pull my finger out of this thing just a little bit. And so it didn't take much. So just make sure the thing's on their finger good. Let it sit there, give it a second. It'll take a second for it to like start working real good. Just give it a second. That's not working. I'm just joking.
there's that pleth wave. You just seen the noise artifact.
Do you guys need a break? You want to take a quick break? All right, we'll take a 5-minute break. Y'all are looking at yeah.
Oh, okay, so it is. Oh, okay, that's nice. So that's still your core temperature. Yeah, so I was should be like, but actually it's.
No, you're fine. You're always 75.
Oh, it's hard to get.
No, the oxygen is
So
96.
rec temperature is 1 degree higher than 12.
Right, in oral was the standard.
Right.
And then axillary, which is an arm.
It's a different one. So it's.
That's what I
It's like a little bag for the baby and version of
It's
the tower. This is my course number one. We're used to do that. He's got soap all over his face. And just like rubbing it on his face, and then he's like looking at his hands and he's like touching his face. And you're just watching them and laughing at him.
Oh my gosh, that's funny. He's such a character. How old is he now?
He's almost 3.
Oh my gosh.
Yeah, so they're like 3 months.
That's crazy.
Yeah.
Hey, Frankie. That's a group.
He loves me when I'm there by myself.
Oh, yeah. So
But
he's
as soon as he's there, he wants nothing to do with me.
I can see how that would be
He likes
confusing.
He loves Ty. We'll walk in the door and he'll like come running up to me, and then as soon as Ty walks in behind me, he like bypasses me, and he like goes to the turns and goes to Ty, and I'm like, "You won't give Auntie a hug?" He's like, "No." Oh, okay. He calls him Bubba.
Oh.
Oh, yeah, mine. So, I don't have my.
You got flying Doritos, man. You got flying Doritos over there, fucking putting it
Hey,
down.
did you see that one that,
There are 2 of them, 2 or 3 of them.
I only seen the one.
Yeah, there's a girl and a guy.
So, I don't know what brand this is. Shut up, Siri. I'm not talking to you.
Hey, whoa, don't say Siri, my phone.
All your phones are like, yes.
I was looking up new ways to say I'm aggravated at my wife today, so I was like, hey Siri, what word can I use to say that my wife is aggravating me? And he gave me like a bunch of them. So I looked at my wife, and one of them was nauseating. I looked at her, I was like, you really make me nauseated.
It's mean.
She just stopped, was like, fucking Siri.
Yeah, I think we'll open up some other professional fund. I think it's open. You can't. Very good too. No, it's working. Yeah, I'm gonna go.
I wish we had one of those water filters.
The water bib sticking out right by the coffee machine. And you can probably get some sort of inline thing.
You guys don't have a water in here?
In the fridge, there's one. It's a 10-year-old fridge.
You guys should just get one of those water jug things, and really Mountain will just come change out your water.
So like the ones that they have.
No, I got it.
Like-
the little have the ice and the water on them.
Those are awesome. I go use theirs all the time.
Uh-huh.
That's where I get all my ice from. They are the best. They have like the best little ice too.
Yep, and I get on with like go fill my cup all the way up with ice, so I'd have ice until the next day.
What time is your meeting? 7?
What?
It happens today.
Yeah. I know.
What, the Phasmophobia?
Yeah, bro.
Yeah. Yeah.
I just saw some comparisons of old versus new Kindle.
There was a big video about it yesterday.
Yeah, they put the summoning circle and the Ouija board are still downstairs.
Yeah, they changed like the monkey paw and
The monkey paws in the garage. The voodoo
Using-
dolls in the nursery.
and music boxes in one of the closets.
Have you guys played Phasmophobia?
Yes.
Their new map came out with it, or their rework, Tanglewood. That's what I'm doing when I get home.
I have no idea what they're talking.
Bitchy game.
The video game.
Oh.
It's a spooky video game.
Been playing some freaking golf though.
It's my hyperfixation.
But I didn't think the liquor store now.
Is it? That's nice. I seen they put, so the car in the garage is like a good looping spot, but they put like the windows in the car so you can see through them, so you can see the ghost. That's cool. It's super nice because the other car you lose the ghost. All right, everybody back. I'm talking about hyperfixation.
You can look in the basement.
Oh yeah, because you can crouch and still see.
I'm sorry.
All right, so blood waves.
Okay, y'all have fun.
All right, you have one. Make good choices.
No. Don't have it.
Okay. So we want a good cleft wave again. Remember, you put the pulse ox on their finger. Some of them have an actual wave. Some of the little dollar store cheap ones, not dollar store, like pharmacy cheap ones. They have like a little bar that goes up and down rather than like a cleft wave. They'll still work. Look at that little bar. See what it does. All right. So, in the state of Nevada, according to Lander County, you can take blood glucoses. In the state of California, as an EMT, you're not allowed to. It is in your scope of practice to do a blood glucose measurement. Now, it depends on your protocol where you work, whether you can or not. But you might be tested on it in National Registry, because that is within your scope. So, they'll be like, oh, I'm moving to California right after this class. I don't need to know this. No, you still need to know this.
Oh, you move there.
I don't know. Some people do silly things. I don't know. All right, so it stands for milligrams per deciliter. Again, they measure things in weird little terms in the medical field. Normal BGL, depending on which textbook you read, or what monitor you're using, or what lab you're using, because different hospitals are different, but 70 to 100, or 80 to 120, that's kind of your normal range, is right in there. So 70 to 100, if they are 65, what is that called? Or 50.
Low blood sugar.
Yeah, what's the word for that? What's the word?
I can't remember.
Hypoglycemia.
Yep, hypoglycemia. Now, if it's greater than 100 or 120, hyperglycemic. The Venus. Or-
I don't know, I check my blood every day and it's never between that 70 and 100.
Yeah, what's yours?
Usually runs about 130, 140.
Yeah, some people just sit like at 130. That's could be normal for them. That's where like they need further testing. Don't like take a patient's blood sugar and it say 130 and like, are you diabetic? And they're like, no. Don't be like, you are now. Don't freak your patients out.
Mine
They
used to run, before I started taking metformin, mine used to run 300 plus.
Really? Did
That's
you feel
bad.
weird when it like first started being lower?
Yeah, really weird,
Really?
like sick.
So I've seen patients like normal for us is 70 to 100, but they'll be like kind of woozy or they'll feel like crap and I'll take their sugar and it's like 102 and they're like, that's way too low for me. I normally sit at like 150, 160, 200. And so like some patients, they live at a certain number and so whenever it actually is low for them, they'll feel weird. So they get used to that. It could be their medication, it could be because they gave themselves too much insulin. Just really depends on your patient. But per the textbook, those are your normal numbers. Again, so hyperglycemia is high blood sugar. I wouldn't freak out like, oh, you're hyperglycemic until they hit like the 300, 400, 500. Whenever the blood sugar reads really high on these, for ours in particular, it's greater than 500. Some of them are greater than 600. When you go to measure their sugar and their sugar is higher than those numbers, it'll just say high. It doesn't give you a number. So it says hi, and you're like, hello. That's kind of a bad day, right?
Now, ours for low is, it just says LO, or, what's the other high one? It might give you an error message. So sometimes you'll get an error message because you put the blood in too soon. So whenever you see these little tabs,
Or you don't fill it up all the way.
yeah, yeah.
That
There's like
happens to me
little,
every day.
got one right here. I'm gonna use one of these strips. So, these should be tested. They come with little test liquids. That'll be like, if you test this liquid, it should say this. So these need to be tested. So you grab your little strip out of here.
You wanna give me a stab right now?
No, I won't stab you. That hurts worse than IVs to me, like absolutely. not.
Oh, my
Like,
fingers are
myself,
so
I sit
sore.
there and I'm like, I hate it. So there's a little like digital looking square, like a little, what's that word called? Like a microchip. Yeah, like a microchip. Thank you. So that goes in there. Once you put it in, don't put the blood on there first and then put it in there. You put it in and you wait for it to do its little thing, and it's gonna give you a little blood drop. So see the little tiny blood drop that's blinking? So you wait for that. Now, whenever you put the blood in, you wanna dip this little thing in. There's a little line, and you want it to fill all the way up with blood. If you don't have enough blood and it only goes halfway, it'll sit there and try to do its little thing, and then it'll pop out an error message. Now, say that I've troubleshooted this and I keep getting an error message. I'm like, I'm doing this perfectly. I've been trained on this. I know exactly how to do it, and I keep getting like error 5 is the one that ours gives. Google that error message, because ours likes to do this cute little thing where it tells us error 5, and that's just like extremely high blood sugar. Like it's higher than it is even able to register high. It'll give us an error message. So we've brought patients in, we're like, we keep getting error messages, and they're like, I don't know, give them an Amputee 50, they're altered. They give sugar, and their sugar's like 1200. Like, don't do that. So it's okay to Google error messages on those things.
Mine goes to 600 and as low as 30.
Really? I think ours, I can't remember if it's 20 or 30. I don't know, I have to look.
Oh, I bought mine at Mills. It works great.
I'm sure these probably can't be those too. I don't know.
So high blood sugar, insulin, low blood sugar, a sandwich.
Sandwich or glucose, your guys' little oral glucose thing on your medication list, that's what they get, unless they're completely unconscious and they don't get anything in the mouth. So they don't want sugars. Huh?
I said aspiration.
Exactly. Could try sticking it up their butt, but I'm not. I don't get paid enough for this. They'll wake up
Not the
with a
glow.
sticky butt. It's not unheard of. Your butt's a mucous membrane. So, you know, the whole butt chugging thing, there's science behind it. But. All right, these should not be unfamiliar to you. Why are words so, am I having a stroke today? Unfamiliar, there we go, thank you.
Unfamiliar.
Maybe you guys should come teach, I don't know what I'm doing. So it might be called end tidal. This is your side stream or your nasal cannula end tidal. This is your inline on the left. That's your inline that goes on the BDM. We talked about all that on Saturday. So ETCO2, who remembers the normal numbers? Good, 35 to 45. So this tells you how much CO2 the patient is breathing out. So it measures it from these little prongs, this little thing right here that hangs down over their mouth. We've been over all this. But it tells you how well they're perfusing on the inside. So if they have a really low end tidal, chances are that they're in some kind of shock, or they have like a blood clot in their lungs. They're not moving blood around very well. And then if it's really high, chances are they've been not breathing for a while. Cardiac arrest patients, as soon as you get pulses back, you'll see this number shoot up. That's like one of our first indicators, like, hey, we got a pulse back, this number will shoot way up. So in cardiac arrest, your normal end tidals like 10 to 20-ish. 20 is like super good compressions, like you guys are doing great. Around 10 is like normally where you'll sit in somebody that doesn't have a pulse. But this is a great tool for a lot of things, and cardiac arrest. So we've seen how it hooks onto the bag. We talked about the waveform. All of you guys see me blowing the little thing on Saturday. Should be like this nice looking square. Again, if it's not a square, okay, you didn't see it. I'm sorry.
No.
I'm sorry. So whenever your patient's breathing, this waveform is reading their exhalation. So this is the start of the exhale, the peak of the exhale. So this is as they start to breathe back in. And this is their inhalation. Yep, you'll see that on the monitor. Ours is a big purple line. So whenever you plug it in here, it'll be a big purple line. Again, you guys don't need to worry about interpreting waveforms of the CO2. Just know that it should be square. And if it's not square, if it looks like a shark fin, or if it does anything weird, make sure you let somebody know. So you can see this line right here is 40. That's telling you that the end tidal is 40. Now, somebody that's in cardiac arrest and has an end tidal of 10, this little square is going to be really, really short way down here because it's only 10. Does that make sense?
And was it the PIP or the CPAP will the normal?
So usually your CPAP will lower it because they're breathing like more off. If somebody's being put on CPAP, a lot of times they have a buildup of that CO2 anyway, because that bronchoconstriction and their lungs hold everything down. So you're kind of like moving it out. Does that make sense? All right. What questions do you have? No questions. Of course, I say that the monitors give you a map, and I picked the picture that doesn't give you a map. Dang it. I need to do better. You guys still good? I know we just took a break, but you guys need another break. No. Okay. Very good. This one's only 20 slides. So nice and easy. If you guys want to hang out a little bit after class or whenever I get done talking, yapping, if you guys want to practice taking blood pressures, I have a stethoscope. It's not the best one, but you can practice. I can go grab my stethoscope off the. All right, principles of the assessment. So, history taking techniques on our sheets, on our medical sheets that we all had. I'm pretty sure there was more printed off the other day. So we have our history taking section of these sheets. So we're going to review techniques on how to take history. We're going to learn pediatric examination tips. Your guys' book is a little odd because it doesn't have like a whole section or a whole chapter dedicated to peds. It kind of just fills it in. I think we already talked about that. So we'll talk about that some. And then we're going to learn how to assess each system of the body. This is the trauma assessment form. But under the medical, you'll see where it says under like your assessment, your secondary assessment, it'll have like integumentary system, GI system, OB system, psych system, and we're going to talk about how to assess each of those. Whenever we're running through these scenarios, even if you're for sure that it's like, okay, I'm sure this is a septic patient, but we still want to assess other things because we don't want to get that tunnel vision. This is sepsis, because what if it's something else, right? We always want to assess everything. So at least 5 systems should be assessed every time you go on a patient. All right, patient history. 2 different components. So history of their present illness. What kind of past medical history do you have? I had a heart attack. Okay, that's their history of present illness. How long ago did you have the heart attack? Have you been taking the medicine for the heart attack? And then why they called EMS. They could have called EMS for a completely different reason. Like say they had shortness of breath, and then you ask them about the heart attack. So that's the kind of differences that we're looking at. So history of their present illness, and then history of why they called EMS. They don't always go hand in hand, but we get them for every patient anyway. We have our past medical history, so they might have a whole list, like, oh yeah, I have hypertension, high cholesterol, diabetes, I broke my arm when I was 3, I have thyroidism, whatever, their whole medical history list. So, you might see these things abbreviated. Whenever you guys are practicing your charting, whenever we start doing your ride-alongs and your writing charts on patients, it's okay to use common abbreviations. There might be a whole list in your book of common abbreviations. It might be in the back. These are acceptable. Like, these are common across the board. Now, don't go making up random abbreviations, because you might get a lot of questions. If there's ever any questions about it, or you're like want to shorten something like patient, sometimes you can write like patient and then in parentheses next to it put PT. So every time you say patient in the rest of your chart, you say PT. But just at first, you like kind of figured out what it was. Do you have a question? Oh, okay. I thought I saw your hand raised. All right. I love this quote. There's a whole podcast about this. It's called Listening in Color. So most people listen with the intent to understand. They don't listen with the intent to understand. They listen with the intent to reply. Who here is guilty of this? Me. Someone will be talking, I'm like, what am I going to say next? Like, I'm not listening to the thing that they're saying. So whenever we're taking a patient history, give them a chance to talk and listen to them. That is huge. That'll get you far, because if you ask Granny, what's going on today? And Granny starts going off about how she feels lonely because her daughter isn't around anymore, but she felt better because her daughter brought her soup last night. But today she's just not feeling it. Well, I got a few things out of that, right? So she's kind of older, her kids are out of the house. That gives me one thing. Why did she have soup? I bring my mom soup whenever she's sick. Right? So was she not feeling good yesterday too? You can get a lot of things out of your patient's story. So make sure you're listening to them. So again, this is my pet peeve. History is obtained by talking to the patient, right? So we talk to our patients. We don't treat them like they're some random scary stranger in the back of our truck. We want to talk to people. I don't feel like you guys are going to have a problem with that, because like the demographic that we got in here. But I've seen this a lot when I was teaching high schoolers, because a lot of high schoolers are used to just doing this all day long. And so they kind of lose those like skills of being able to talk to somebody. I don't think you guys will have a problem with it, but I just like to talk. All right, if you cannot talk to the patient, they have family members, bystanders. Do they have medications present in their house? Do they have any kind of medical jewelry? Other things that you may observe at scene. Again, like somebody's leaning over a freezer and they can't breathe. That kind of tells you one thing, right? So, Croup, yep. Yeah, they'll get like this usually seen in kids, but they get like this weird seal like cough thing. It is gnarly. It sounds really bad. Oh, I put way too much lemon in that. Other things you might observe at scene, talking about like drug overdoses. The last cardiac arrest I worked, the guy had a thing of Narcan laying next to his head. So someone tried to give him Narcan, called 911, and then left. So just, I couldn't get history from anybody because there was nobody in the house, except for this dead guy. But he had a Narcan thing like next to his head. So that kind of tells me, like, okay, maybe a history of this, or they kind of have some knowledge about it, and somebody tried to administer this. So those are things you kind of want to take note of. Another thing I've really noticed on overdose calls, ice cubes. People love to dump ice on unresponsive people. And I don't know why, but they'll be like soaking wet and covered in like ice. And I'm like, okay, I don't think this is gonna fix up, but whatever. I don't know. Like ooh, he needs some milk. They're dumping milk on people. I've seen that too. People dump milk on people. Weird. All right, so history taking. Make sure you're developing a rapport with the patient. We talked about body language earlier in the class. This is kind of where that kind of fits in, right? So we're talking to the patient, we're getting at the eye level, unless they're aggressive or like I feel like they're gonna switch. Any kind of sight patient, if I walk in and they're like, I'm not gonna be like, how's it going today? I'm gonna stay back. But you know, older people, see how she's at that same level as your patient. What's an open-ended question?
That's the next journey, yes or no.
Good, yeah, so what's going on today? That's an open-ended question. If you need an immediate answer, you can use closed-ended questions. But make sure whenever you ask your question, you're listening to their answer, right? My problem is I have a list of things I'm gonna ask a patient before I even walk in their front door. They call for chest pain, I have a whole list of things I already know I'm gonna ask them. And I'm like, okay, what's my next question? What am I gonna ask them next? And I forget to listen to them. So it takes practice. Oh no, my little thing didn't work. I'm supposed to go, like, each of these were supposed to be their own thing. Dang it. I swear it worked whenever I ran this through the other day. All right, OPQRST. I've seen this written on the board where you guys were doing your medical scenarios with Mikey. So you probably talked to some about this stuff. So this is our little acronym that we use whenever we hit our history taking, part of our medical sheets. So O stands for onset. If we don't walk up to the patient and say, what is your onset? Like, those are weird, right? So, some questions, yeah. Like, what's your provocation? They're gonna be like, get out of my house. So when did this start? That's a good question to ask, the onset. When did this start? That's super easy. Provocation, so does anything provoke the pain? Does anything make the pain or whatever you got going on better or worse? Quality is them describing the pain or the feeling or whatever they have. I will say, I've noticed if I'm asking a patient, like, what can you describe your chest pain to me? And they're going, I don't know. And you're like, well, is it sharp? Yeah. Is it dull? Yeah. Is it feel like an elephant sitting on your chest? Yeah. So it's gonna be yeah to everything if you give them the answers. So have them describe what it is, because they're gonna be like, yeah, that's what it is. But sharp and dull are two different things. Yeah. Both. Okay. All the above. All of the above. Yeah. So don't be like, does it feel like a bee sting? Yeah. I don't know. And then radiation or region. Where is the pain and does it move anywhere? Or like if you're gonna use like somebody that doesn't have a pain complaint, like shortness of breath usually isn't painful for some people. You can ask like, do you feel this mostly in your chest? Are you feeling it in your back at all? Do you feel it up into your neck? So sometimes you'll ask like, describe the pain. And they're like, I have no pain. And you'll go to the next one and you're like, okay, it's R. Does your pain move? And they're like, I'm not in pain. So these questions can be asked about other complaints. But sometimes it's kind of hard, like it's kind of obvious, like if they have shortness of breath, like obviously it's gonna be in their chest, right? Sometimes they feel it up in their neck, so those are some questions to ask. And then your severity, everybody knows the question on a scale of 1 to 10, 10 being the worst pain ever. What's your pain or discomfort at? And then your time. A lot of people get the O and the T mixed up because they're very similar. It's onset and time. Have you experienced this before, or how long, like, have you been dealing with this problem? So, like, if someone has shortness of breath or chest pain, and they have a history of it, you're like, yeah, I've been dealing with this for years. That would fall under your time. Have you experienced this before? Whereas onset is this specific time that they called. When did this episode start? Does that make sense? Mm-hmm. Those two can get kind of confusing. All right, sample. This slide worked like my last slide was supposed to work, hopefully. What's your S? Oh, what's your S? Good job. It will work, I promise. What's your A? Allergies. Good. M? Medications. Good. Oh.
Pain history.
Good. Pertinent history. What's your L?
Last oral intake.
In
Good.
and out.
Yep, last ins and outs. So I was always taught last oral intake, and then I've noticed that your guys' I think it's your book or something. It was drilled in my head at some point to be like last ins and outs. So last in, last out. What's the last thing you ate? What's the last thing you drank? Have you been using the bathroom regular? Poop today. I know it's weird to ask strangers, like, we just met, but did you poop today? And then what's eat?
Events leading to the injury or illness.
Good. So you kind of get this a little bit as you're getting your OPQRST, right? The events leading up to. So sometimes if you don't get it in the OPQRST part, you can ask it now. But sometimes you kind of check that little box when you're on your OPQRST. So these are things I recommend memorizing. I'm going to say to memorize it. 7. And late.
I wasn't last week, they were super early.
Yeah. They just do whatever they feel like. So memorize these, the OPQRST, the sample, whenever you're practicing your sheets, make sure you're asking these questions. All right, kiddos, preschoolers, if you use simple language, that's a good way to assess them. A lot of times they can kind of tell you what's going on as long as they're not terrified of you. They're just saying they're holding mom's leg, like, who is this stranger? But a lot of times they'll chat with you. School-age children, they can describe what they're feeling or what happened, and then ask the parents, teachers, care providers. If you're dealing with like an abuse situation and they're, they need to be separated from their parents for whatever reason. Older siblings too, I've noticed. If I'm having to separate them for whatever reason, it's like an abuse situation. Usually I'm assessing all the kids, and so they'll kind of tell me all what's going on. So siblings, they can help. A lot of times siblings are the babysitters. Like if they have older kids in the house too, you get called for a 2-year-old that smacked their head. Usually, like teenagers will be around. So we have these fancy little ED mates. Did Chaz show you those on Saturday? The little seatbelts for the kiddos.
Mm-hmm.
That's what this little red thing is behind the kid. It's called a PD mate. It straps right to our stretcher. So they need to be strapped in. Per the law, the moms or dads or uncles, whoever family member, is not allowed to hold the kid while you're transporting. They both need to have their own seatbelts. So this is the kid's seatbelt. Mom, dad, brother, sister, whoever's taking care of them, needs to be sitting with their own seatbelt on. Do we wear seatbelts all the time? No. Are we supposed to? Yes. Yes. But if I'm doing stuff, I don't have time for seatbelts. They do make some now that like reach way out so you can like bend over and take care of your patients. We don't have those. They're good. All right, physical examination. Touch your patients. Right? So before, during, or after pertinent history, look, listen, and feel. You keep it talented. Face. So look at your patient, listen to your patient, auscultate, and then feel. So whenever we palpate, if you're palpating like a belly, make sure you're actually palpating. I've seen so many people that are like, yeah, I'm palpating the belly. Like actually feel the belly. Now don't be like, but like actually palpate the belly. For kiddos, for your physical exam, make sure you're approaching them slowly. You don't want to be this big scary stranger. Like, hey, let me take care of you. Start with the toes or trunk. If mom's holding them, you can kind of mess with their feet a little bit and kind of work your way up. Some kids are like fine with you, like assessing them. Some kids do not like it at all. So you kind of got to build that rapport with the kiddos as well. Explain equipment to kids. If they have like a little stuffy that they got, if they're scared of the blood pressure cuff, I'm like, let me put one on mom. And then usually they'll kind of warm up to it. I also like to do the like distract technique. So I'll hand them something and they'll be like messing with it and I put a pull socks on their finger. Whereas before they'll like rip the pull socks off. If you kind of distract them. Don't lie to a kid. I know that's kind of obvious, but you're about ready to stab a kid for a VGL and they ask you, is it gonna hurt? I'm not gonna say, no, it doesn't hurt at all. And
and then stab them. Like, no, it's gonna hurt. Like, don't lie to them. It just feels like a little bee sting, you know. But because my first instinct's like, yeah, tell them it's not gonna hurt, so they let me do it, but it's not gonna help. And then protect the patient privacy. So kids, they're like their own little independent selves. So obviously parents in the room. If you start dealing like with older kids, teenagers, they're gonna want their own privacy. So if you're doing like an assessment for whatever reason, whatever kind of assessment, ask them what they're comfortable with. If they want their mom or dad back there. Sometimes you have like teenage boys that like don't want their mom to look at them. So just make the patient comfortable. All right, assessing the respiratory system. Number one question you should ask yourself is the patient breathing, right? If the answer to that is yes, then we auscultate breath sounds. What's it called if they're abnormal? Adventitious. Adventitious. Mm-hmm. Now, if they have a respiratory complaint, I'm still going to be looking at their feet for that edema, right? Do they have some kind of fluid buildup? If they had fluid buildup this bad in their feet, chances are they might have it starting in their lungs as well. So it's important to look for edema. Again, even if somebody's feet don't look like this, we actually had a patient like this my last shift or the shift before. His legs looked pretty normal, but then you poked on him and he had those little edema marks. It's important to make sure that you're actually like assessing for this. And then if your patient has a fever, so that can kind of tell you, is it like a pneumonia thing? Is it an infection thing? Or is this like a chronic COPD thing? You kind of, go off the two. What are adventitious? Adventitious, yeah. Adventitious, maybe? Adventitious.
When I was going through the other son, like that, they were pumping it full of like an IV. Hey, is it supposed to? Or I said, oh yeah, that's fine. Hey, is that supposed to? And the activated, oh, and turned off. Yeah, oh.
Yeah,
She's sitting there
oh.
like inflating. I was like, oh shit.
Why should it like the mission?
I was like, he stops.
Yeah. That's another thing, like once you guys move a little bit further and you can do IVs and give fluids and someone has this, you can still give them fluids, but make sure you're not dumping it into them. Like, please don't do that. You don't want to drown your patient. All right, now if your patient has chronic breathing problems, what medications are they on for it? Do they take them as prescribed? So we want to know if they're compliant with any medications that they have. And then ask them, do these, have you experienced this before? Does it feel the same? And then like we were seeing with that last video on last week's slide where he's like, hey, how many times have you been intubated? Have you ever been intubated? Those are important questions to ask breathers or anybody with respiratory distress if they have it chronically, because it can kind of give you a gauge of like how sick they are. If they're like, oh yeah, this is nothing, and they look like crap, but they've been through all this before. Like, listen to your patient. What kind of medicine might they be on if they have like asthma?
Albuterol.
Good.
Much less tap.
Yeah. Do you have asthma? Okay. Cheater. Yes, that would be it. I have a little fake albuterol inhaler that CJ bought last year, so you can practice. You're not supposed to actually inhale it, but you can see. All right, cardiovascular system. So look for signs of perfusion. Right, so are they cool, pale, diaphoretic? Are they pink, warm, and dry? Look at their skin. Is it blue? Like, look at your patient, right? Observe their posture and their breathing. Now, if someone has like chronic CHF or congestive heart failure, a lot of times they can't lay flat on their back. If you try to lay them flat, they'll kind of freak out. They feel like they're drowning. set them up a little bit. Someone's complaining of like chest pain, we're always gonna be palpating our pulses anyways, but make sure you palpate their chest. Sometimes someone does a lot of heavy lifting, and they're like, yeah, I have chest pain, you go to poke on it, and you're like, ow. A lot of times your like heart attack, don't rule it out entirely, but a lot of times your heart attacks aren't painful to palpation. There's always like those weird one-offs. I'm not gonna say rule it out entirely. Another thing you can kind of do is any kind of like muscle thing. If you have them take their hands and push them together and it hurts them, that's kind of the same thing. Like you're palpating, you're feeling the muscles in their chest. Sometimes it's just a muscle problem. And then if they have chronic conditions, so medication compliance, again, history of similar episodes, you want to obtain that history of present illness. What is this?
But is the patient sitting up or laying down?
Either or.
Because it's normal when they're laying down, right?
It can be. So if you're laying flat and someone like pushes on your liver, you're going to get JVD. It can be normal if you're like holding your breath, it can like, but if someone's just sitting there, whether they're laying there or just kind of sitting up, and you see it this big, that's really bad. But like normally you'll see a little bit if they are laying down. But yes, that's called JVD. So jugular vein distension. So if someone has a lot of fluid backing up into their lungs, a lot of times they'll have the JVD. It's like a buildup of pressure in their chest, and it'll cause those veins to distend. Another thing that can cause it is like your pneumothoraxes. That can cause JVD, and that tamponade, that pericardial, like tamponade, where that sac around your heart starts to fill with blood or fluid, it can cause JVD. Make sure you're looking at your patient for that. If it's ever that big, it's not good. Did everybody have that written down? Get hand cramp. All right, AVPU. So we're examining their mental status. So we did the AVPU, right? So alert, verbal,
Thankful,
unresponsive, right? If it is abnormal, what is the patient's normal? So some people kind of live in an altered state. So if there's anybody around, ask what's going on with the patient. Is this normal for them? What's a fast exam?
Face, arms, spinal tap.
Not
Stroke,
spinal.
right?
No,
No,
this is
spinal.
mine.
Oh, I thought you said spinal. I was like,
I didn't think I did that.
Let's check the spine. Yeah, good. So fast. So we use the fast exam. The Cincinnati is very similar to the FAST. The only thing that the FAST has that the Cincinnati doesn't is the time part of that, the T. But you should still be getting time if you do the Cincinnati scale. I like the FAST. Just know that that's a very basic stroke assessment. Somebody could still be having a stroke and have a negative FAST exam. But you guys, if you're seeing someone that looks like this, that kind of does the FAST exam for you, right?
I was totally asking that. You see, Rob? 11.
Yeah, 11. The purple banana hand, it's blue on Tuesdays, and you're like, oh no.
He's fasting.
Yeah, this is bad. All right, so when we're assessing the nervous system, we can look at pupil. We want them to be PERLA. What does PERLA stand for?
Equally round and red. The light and accommodating.
Good. Pupils equally round, reactive to light, accommodating. All right, what's a gait? Walking, yeah. So I think I have yes. My next video is this lady that has a weird gait. You can kind of see someone's having a stroke and they're walking funny. Some people, that's their only sign of a stroke because they randomly start to walk funny. I've had that patient exactly. And his only complaint was he wanted a sandwich. He called 911 because he wanted to go to the hospital to get a sandwich. And as he started walking my stretcher, he was doing like this weird number, and I said, "What you doing?" And he's like, "Oh, I started walking like this earlier." So I called a stroke alert. He was having a fat stroke. huge bleed in his head, and all he cared about was his sandwich and soup. He wasn't even altered. He just wanted, like, he could answer all my questions. He just wanted soup. All right. Great. Any signs of dysfunction in the body? Numbness, tingling, weakness in like any one limb, any kind of neurologic symptoms. You should be assessing this. And then history of neurologic conditions, and then talk to your patient, have them repeat back to you, right? So the S part of the FAST exam is speech. So one thing you can have them say is, "It's always sunny in Cincinnati." You can't teach an old dog new tricks. Just have them repeat a phrase back to you. And if it's really slurred, or they talk like they have marbles in their mouth, or they just say some really offhanded shit, their speech is affected. All right. Yeah.
So the history of neurologic conditions,
Mhm.
what kind of conditions?
So any of them. So if you're talking about like a multiple sclerosis, that could be like a neurological condition. Somebody could have like history of seizures. That's considered a neurologic condition. Some people will have like shunts placed in their head. So you'll see like a big scar and you ask what it is and they'll say shunt. So that's to help drain their CSF fluid. That's neurologic. So it could be like a huge realm of things, right? So Parkinson's is considered neurologic. There's a laundry list.
People are more likely to get strokes if they've had like Parkinson's and stuff.
I don't know if Parkinson's in particular, but I do know like you see the AHA signs everywhere, like history of high blood pressure, high cholesterol, that they're non-compliant with their medications. They're like at a predisposition to have strokes, right? So not all strokes are gonna present like normal, but sometimes someone might present like they're having a stroke, and it might just be part of their condition as well. Like Bell's palsy, like everybody's seen that Bell's palsy face. It looks like they're having a stroke. If you ever question it at any point, just call the stroke alert. Just say, "I'm bringing in a stroke alert," because I'd rather call one and it not be a stroke and I look kind of goofy than me bring in somebody that's like having a stroke and I didn't call it. That makes me look a lot more goofy if I just don't. All right, so here's an example. This is called ataxia. She's got it on her shirt. So you might see this. Sometimes if I'm concerned about like a neurologic problem, like a stroke, I'll have them walk to the stretcher just so I can watch them walk.
So just take my hand here, and we'll just move it.
And again, if someone's walking like this and be like, "Okay, I need you to walk," help them. Don't just be like, "Fly, bird," you know?
Got your balance?
Yeah. That would be so frustrating. Like if that was your normal, that would be so frustrating. So anytime you assess the neurologic system, it's not always like, okay, I think they're having a stroke. But we always just want to assess it anyway, because some other things can cause neurological problems. Tumors, blood sugar problems can cause neurological issues. But talking about blood sugar, we're talking about the endocrine system. So the most common patient that's experiencing something wrong with their endocrine system is the diabetic. So ask them, have they eaten recently? Have they taken their medication? Have they exerted any kind of energy lately? Or are they sick? So the number one cause of somebody having like a hypoglycemic or hyperglycemic problem is because of some kind of infection. So whenever we get infections, even somebody that's not diabetic, your blood sugar goes up. Because our cells are like, "Hey, you need to go fix the problem," so it's giving extra glucose out. So you might see a slight rise in blood glucose anytime you have somebody that has like an infection or something like that. What kind of medication are they usually on if they're diabetic? What are they on? Insulin, metformin, Mounjaro, the like shots. Yeah, semaglutide. Yeah, all those. You might have somebody that has like an insulin pump, so make sure that you're monitoring, like ask them if they're monitoring that. Sometimes people have like a little
Dexcom.
yeah, Dexcom, thank you. That'll go on their arms and they can read it from their phone. So those are kind of cool too. Another part of the endocrine system, they have a history of thyroid. A lot of times with your endocrine problems, your patients, these are patients, unless it's like a diabetic problem, these are patients like thyroid problems are really hard to differentiate in the field. So if someone's having like a thyroid storm, it can be hard to say, yeah, they're having a thyroid storm, just pre-hospital. It's like where they get a release of too much thyroid hormone, so they start to get like really like tachycardic, febrile. A lot of times I'm trying to think of what causes it, like specifically. I can't remember. I know like tumors can cause it. I don't know if certain medications can cause you to go into like a thyroid storm. But they're hard to recognize. Because you want to think of everything else first. You're like, oh, it's drugs, or oh, it's this, but it's hard to pinpoint what it is. For the endocrine system, especially with like your diabetics, assess your ABPU and your GCS. What is GCS? So it's your Glasgow Coma Scale. So highest you can have is 15, lowest you can have is 3. If anybody ever tells you that they have a GCS of 0, they need to count again. So someone that's completely unconscious, unresponsive, that's a GCS of 0. Look for medical jewelry, and then look for an insulin pump. We'll get more into the weeds about GCS a little bit more, I think either Thursday or the next Saturday that you're here. You'll know it very well.
What was it again?
It stands for Glasgow Coma Scale. What it is, it's a scale we use per numbers to kind of tell us the alertness of our patient. It was originally designed to assess the severity of head injuries, and then somebody in EMS was like, this is great for everybody, so now we do GCSs on everybody. So 15 is like walkie-talkie, they're looking at you, they're altered in any way, then that number starts to go down. So you'll see all the criteria for it eventually. Then get a glucose. So you're obtaining a glucose. Any patient that's altered needs a glucose. Any patient that had a syncopal episode. Any patient that has any kind of neurological symptoms, especially a stroke, get a glucose before you call a stroke alert. Because that is the most common mimicker of a stroke is low sugar. So it also, we've all done it, but we all look really silly rolling someone in that's like, looks like they're having a stroke, and you're like, what's their sugar? And you're like, shit, got to get it. And they take it, it's like 12 or something. All right, the GI system, intake, outtake. What have you eaten? Have you puked? Have you pooped? All that, any kind of pain or discomfort. Whenever you're talking about like pain or discomfort, have them kind of describe where it's at. And then whenever you go to look, listen, and feel and palpate the furthest quadrant away from where they're complaining of their pain. So if they're complaining of left lower pain, I'm going to palpate right upper and then kind of move around and palpate that area last. Because if someone's like, yeah, I have a lot of pain right here, I'm like, let me poke it, they're not going to let me touch the rest of their abdomen, right? You want to assess everything else and then the painful spot. Also, whenever we're talking about your abdomen, is it distended? Is it rigid? So whenever you go to palpate it, do you feel like any hard lumps in there? Do you feel a pulsating mass? Like is there a mass in there that you feel a pulse on? That's a bad day, but take note of that. Triple A. Oh, it's like your aortic aneurysm. That's
Stroke is a blood clot in the brain, right? An aneurysm is not like a swollen vein.
So it's a swollen artery. So yeah, you can have two kinds of strokes. So you have like more ischemic stroke, which is like a clot in the brain, and then you can have like an aneurysm in the brain that causes a stroke, which would be like a hemorrhagic stroke. So they're bleeding out into their head. So what happens is your arteries have 3 different layers. What happens is that inside layer kind of tears off, and that blood will start to fill in between the layers of the walls of the artery, and it'll start to bleed out. So that itself is called an aneurysm, and it can rupture, and that's a whole nother. But if you're feeling like a pulsating mass, that's usually an aneurysm, unless there's something. I'm sure there's something benign that causes it too. But. All right, so the immune system, we're gonna assess for allergic reactions. So that is the most relevant part of this. We have people that have like immune system problems, they're immunocompromised. If they have those kind of problems, that's part of your history taking. If somebody ever tells you something random like, oh yeah, I have blah, 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 itis disease, and I have no idea what it is, just ask them, like, what kind of symptoms do you experience? Like, I'm not familiar, will you educate me? Because a lot of times with like the immune problems, like the chronic immune problems, I'm not well versed on that stuff at all. History of allergies, if they've had a contact with something that makes them go into any kind of allergic reaction, that's important to know. Tightness in the chest or throat, if you see this, hives, right, that's not good. Inspect the skin, inspect the airway, so look in their mouth, look at their little uvula, if that thing's swollen, that's a problem. Listen for wheezing, any kind of stridor, we're gonna listen to everything. And then as the patient speaks, if they sound like they're talking through marbles or they have like a really hoarse voice, what medicine do they need? Epi. They need their EpiPen. Good. All right, musculoskeletal system. So muscles and skeleton. So whenever we're talking about our trauma sheets, you guys have those too. We'll go through like the whole trauma assessment. You'll see us do one, and then you guys can practice doing them yourself. We're gonna palpate the limbs if someone's unconscious. Even if somebody is conscious and they've been through like a major trauma, we're gonna palpate everything. We're gonna feel all the bones in their arms, legs, chest, back. Ask about prior injuries. If you have like an old injury in some of your bones, if they have underlying diseases or conditions like osteoporosis, or like bone cancer would be a good example of that. Like their bones get brittle and weak, and so that can make underlying like their fractures more common. Jeez, I tell you, I'm having this stroke. Any kind of musculoskeletal thing, you want to ask the patient if they're on blood thinners. So blood thinners can make internal bleeding a lot worse, or make internal bleeding that like someone that is not on blood thinners. It can make bleeding happen. So make sure you're getting a history if you can. Again, if someone's completely unconscious and you can't get a history, what are you gonna do, right? So that's where you look for that medical jewelry and stuff, but a lot of times you won't get that. Sorry.
You're okay.
I like to just stand right in the way. Almost done, I promise. All right. Now, whenever we're assessing the musculoskeletal system, who here has heard of ECAP-BTOS? ECAP-BITLS. So this is, again, another acronym that we use. So what does the D stand for? Good. So deformity, C, contusions, A, abrasions. Someone else besides Shia? What's P? Punctures. All right, who's next? B. Burns. Good job. All I saw was his face. What's T? Shia?
You're gonna say it, and I'm like, yeah.
Tenderness. What's L?
Laceration.
Good. Lacerations. And what's S? Screams. Are they screaming? Swelling. So, whenever we're going through our assessments, and I start my physical assessment on my trauma patient, on my trauma sheet, I'm gonna say I'm looking for DCAP BTLS, right? And then your proctor is gonna say, but what does DCAP BTLS stand for? So you're gonna have to rattle all this off. It'll come to you. Because practice makes perfect. So, deformity, contusions, abrasions, punctures, burns, tenderness, lacerations, swelling. And then for the rest of my assessment, I just say, checking for DCAP BTLS, because I already proved what it was, right? So, memorize these. That's what they stand for. That's what you're looking for during your trauma assessment. It's DCAP BTLS. We got it? All right. And then we're going to compare the sides for symmetry. So if you see something abnormal like swelling, check the other side. So sometimes people's bones and like joints just look weird. That's normal for them, and they'll look the same on both sides. So you see like this side's a little bit more swollen, the knee cap like doing this little weird C number here, and that one's not that way. So make sure you're checking both sides. All right. Everybody's favorite part of this, diagnosis. So diagnosis by definition is a label for a condition, right? As an EMT, you cannot diagnose somebody, but you can form a field diagnosis. Because in your head, you're still making a list of like, well, this could be wrong with them, this could be wrong with them, I'm treating them for this. So that's my field diagnosis. What am I treating the patient for? That wouldn't be like, well, I'm not going to treat you because I can't make a diagnosis, right? So you still want a field diagnosis, but you can't diagnose somebody. So if you're ever asked, what's your field diagnosis, or you might hear it like worded like a differential diagnosis. For every patient, like if you're writing with me and we're talking about it, once you guys start getting through your assessments and we have a patient, I'm going to ask you for 3 differential diagnoses on every patient. And we should never get that tunnel vision. It could be the most obvious diabetic you've ever seen in your life, and I still want 3 differentials for every patient. So we don't want to get that tunnel vision. That's where we get in trouble. Again, we're not going to get tunnel vision. All right, so whenever we make a list of differentials, like for example, if someone's having stroke-like symptoms, the top of my list for differential is going to be stroke. There's one, right? Second, I'm going to say, are they diabetic? Is it a diabetic emergency or hypoglycemic emergency? That's going to be on my list of differentials. Another thing, it could be like a tumor. Could they have a tumor? Could they have a head injury? Did they fall and hit their head? Now I have 4. So you should be able to pull 3 out of your little hat. But if you pull out more, that's good. It's good to keep an open mind.
Do you give, when you pass off a patient to the hospital, the nurse or the doctor, do you give them all of your differential diagnoses or just your most probable?
So whenever I'm giving a report, and I think they mentioned this in your book too, I try not to give like a probable differential diagnosis in my report. I just lay out the signs and symptoms that I see. But sometimes, like, if I'm concerned about something that's a very particular thing, I'll say, well, I'm concerned about XYZ. I won't be like, my differentials are this, 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 and this, but I'll just give them everything that I've seen. And then if I'm concerned about one very particular thing, I'll pick it up. But that's kind of be different, like who you're working with. Like we're really close with the nurses over here. We deal with them a lot. Like we have a good working relationship, so we can talk like that. But if you ever get to like a bigger city, you walk in and you're like, well, you know, I think that this is wrong with them. You might get somebody that gets, you're not allowed to diagnose. I'm like, okay, get out of my face.
My field diagnosis.
My field diagnosis. Exactly. All right. So whenever you have a field diagnosis, our biggest concern is treating our immediate life threats, right? So our ABCs, airway, breathing, and circulation. We're gonna fix that problem first. We're gonna gather information. This is basically just going down your skill sheet. So ABCs, gather your information, get your history, do your exam. Whenever I'm making a list of differentials in my head, what's gonna kill them first should be at the top of my list, right? So like stroke, that's gonna kill them first. Or glucose, that could kill them quicker than a stroke, but I wanna rule that out. So make sure that you're dealing with something, you're gonna think the worst case scenario first. Does that make sense? Rule it out. And you may be responsible for multiple patients. This could be an MCI kind of thing. This could be a whole family has COVID and they called you and you have a family of 5 all with a cough. Now you're dealing with all of them. It could be some kind of exposure to like gases or whatever. Now, if I have 5 people that walk out of a house and I can smell the propane or smell the generator and they're all like, I have a headache and she's in there unconscious and puking, like I can kind of say, okay, my differential is going to be like carbon monoxide, right? So make sure you're like assessing your sleep and getting info out of that. I'm sorry. Okay, got it? Okay. All right, so this is my last slide. I think I'm going to read it on time. This book right here, if you ever get the chance to read it, it's kind of interesting. This was like 10 more slides. I condensed it down to 1 because they went into like how doctors make their diagnoses and how experienced doctors figure out what's wrong with the patient. Biggest thing is once you have seen so much or you've seen so much of one thing, you kind of create this little shortcut in your brain. Like I've seen this before, so I'm going to suspect that it's this. The thing about this book is this guy follows around firefighters in like New York or something, some big city, and he watches them make decisions. And so there's an example in the book where they're sitting there fighting a fire and it hits a billboard and the chief is like, hey, you need to move these people right here to over here. And like as soon as they move, that billboard like collapses. And the guy questioned him later, he's like, how'd you know that was gonna fall right where they were standing? He's like, I've seen it before. So I was able to make that, connection really quick. And that's kind of the whole point of this book is like, where do we draw our decision-making factors from? And a lot of it is just pattern recognition and seeing the same thing over and over again. So part of this job, we need to form a strong foundation. So that's why we're in this class, right? Because good BLS is going to save ALS every single day. We're going to learn from others, whether that's something that they did good or something that they did bad. And then we're going to learn from our own things. So like, this is why it's really important to debrief after every call, right? Even if it's just something silly and you're just chatting with your partner about it. I'm not saying have a whole like meeting with everybody that you work with, like, let's talk about this call. But it is important to chat about it. Like, what did we do good? What could we have done better? What are some things that we may have missed? That's really important. But if you ever get some spare time, this book's pretty decent. Anyway, that's the point away. Tell you all that. All right, what questions do you have? Sorry to keep you so long today. Everybody good? Does anyone want to practice blood pressures? Not today. All right, so next Thursday, this Thursday, test over what we just went over, and then what's our next thing? You guys are still good. 15 and 16, the secondary assessment. I combined 15 and 16 in one PowerPoint, so we should have some time to kill on Thursday. Yeah, it was so short. I was like, this is ridiculous.
Hopefully it's like 12 questions, right, or something like that.
Yeah, probably. It was super short.
I think it was like 4.
It was 4. It was 4 questions. I got on there and I was like, 4.
Yeah, I was making a PowerPoint. I was like, this is ridiculous. Why is this a whole chapter in itself?
They should have just put it there with another.
Yeah, they should just combine them, but whatever.